From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Thanks for tuning in to this JAMA Cardiology podcast. I'm Anne-Marie Navar, Deputy Editor at JAMA Cardiology and Associate Professor at UT Southwestern Medical Center. I'm joined today by Dr. Michael McDermott. He's a British Heart Foundation Cardiology Research Fellow at the University of Edinburgh, and Dr. Pam Douglas, the Ursula Geller Distinguished Professor in Research in Cardiovascular Disease at Duke University. Today we're discussing the manuscript Impact of CT Angiography on Healthy Lifestyle Behavior and Preventive Therapies, published in JAMA Cardiology. Dr. McDermott is the lead author of this manuscript, and we're pleased to be joined by Dr. Pam Douglas, who was the senior author of the accompanying editorial. Dr. Douglas, Dr. McDermott, thanks for joining us today.
Thank you for having me.
Thank you, a pleasure to be here.
So let's start off briefly, Dr. McDermott. Would you please summarize for the audience, first of all, the SCOT-HEART 2 trial, and then can you go on and tell us about the nested substudy?
Of course. So the IMPACT study was a nested trial of the SCOT-HEART 2 study. And that is a British Heart Foundation funded study, which is currently ongoing. It's an open label, parallel group, randomized control trial, which is comparing CT coronary angiography for the screening of coronary artery disease, comparing it to cardiovascular risk scores, recruiting asymptomatic participants without known cardiovascular disease aged between 40 and 70 years with at least one cardiovascular risk factor. The sub-study, we wanted to explore the impact of both risk scores and coronary CT angiography on an individual's perception of risk and whether it led to healthy lifestyle behaviours, cardiovascular risk modification, and overall change in their cardiovascular risk prediction over the subsequent few years.
So the trial in which your study is nested is randomizing people to either receive a risk score and then preventive therapies based on that, or undergo a CT angiogram and receive tailored therapies based on that. Before we get on to the substudy, maybe I'll ask Dr. Douglas to comment a little bit on how this SCOT-HEART 2 trial fits into the current landscape around imaging and cardiovascular disease prevention, and what you think about the overall study in which this is nested.
SCOT-HEART 2 is a wonderful exploration of what we need to do to right-size prevention for an individual. So risk scores are tried and true. We've had them since the 1960s with the Framingham Heart Study, but they're epidemiologically based on a population risk, and they don't tell us very much about an individual's risk. And in the last 20 years, we've learned that coronary calcification information from CTA is a far more powerful risk predictor for an individual, and in fact dictates that some people should have preventive therapies like statins, even if they're low clinical risk, whereas other people that are high clinical risk but are somehow resistant or resilient to coronary artery disease probably don't need to be on statins. And so we've known that as an epidemiologic predictor, and we've just started to find out about that as a guide to therapy. And there have been two recent trials that focused on that. The first one, Notify, informed individuals and their clinicians of incidental coronary calcium on non-gated chest CTs, which led to a 7-fold increase in statin prescriptions in this relatively high-risk group with 17% 10-year risk. In the more recent one called COT-CAD, a calcium score was used to manage familial hereditary coronary artery disease and found that a much better control of atherogenic lipids and actually reduction in coronary plaque progression with usual care. But the SCOT-HEART 2 trial takes this a step further It's an all-comer trial. It is a head-to-head comparison of risk score versus CTA rather than coronary calcium. And it's going to be fascinating to find out the results of that. The current paper, the impact paper, this nested sub-study, gives us an idea of what the short-term impact is over 6 months on preventive measures, including therapies as well as others, as well as a risk profile.
While we're all anxiously awaiting the results of SCOT-HEART 2, which will tell us if imaging-based strategy prevents coronary disease death or myocardial infarction, we're really excited to have at least some early results of how this scan is changing behaviors in those randomized to a scan versus risk-based scoring. And so, Michael, if you don't mind, can you please just tell us a little bit about what you found in this nested sub-study about differences in behaviors?
Yes, of course. As you said, Dr. Navar, we were very keen to explore the impact of CT coronary angiography and on risk factors and how it affected people. So we conducted this sub-study between September 2020 and January 2024. And in that period, we enrolled 400 participants, 205 to coronary CT angiography and 195 to cardiovascular risk scoring. And our primary outcome was a composite because we wanted to understand the impact it had on a number of aspects on people's lifestyle. So that was on their weight, their smoking habits, their physical exercise habits, and on their body mass index. And when we put that together, we found that in those randomized to coronary CT angiography, 33 achieved all of those domains. So that was 33 out of 195, which was 17% of the overall population. And when we compared that to cardiovascular risk scoring, we found that it was only 6% that achieved all of those domains. And I think one of the most striking things about undertaking this research, and in someone who was quite involved in meeting the majority of the patients in the study, the numbers seem quite low for the primary outcome. I just want to highlight that achieving all of those things was actually very difficult. And that's something that we observe in other studies, particularly in primary prevention, and that adopting all these healthy lifestyle behaviours is something that the individual finds exceptionally difficult. However, we have shown that with coronary CT angiography, participants were more likely to achieve the primary outcome.
And just to follow up on that, the composite was a pretty high bar, but Pam told us a little bit about the preliminary data and trials showing increases in statin utilization and improvements in lipid control. What can you tell us about what happened on the lipid side of things in your sub-study?
In the sub-study, of the 205 participants that underwent CT coronary angiography, we actually observed that 100 patients had normal coronary arteries, so they did not receive any recommendation beyond lifestyle recommendations. And we found that 86 had non-obstructive coronary disease and 19 had obstructive disease. So of those 205, 105 participants, as per the main SCOT-HEART 2 trial, they had a recommendation for lipid-lowering therapy and antiplatelet therapy with an aspirin. And when we look at the adoption of the lipid-lowering therapy relative to those who had cardiovascular risk scoring, patients were much more likely to accept the recommendation of what we felt their risk was, and we were much more likely to take preventative therapy. And we can see that in our study. So in table 2 of our study, we can see that 105 patients were recommended preventative therapy, so 51% in those undergoing CT, compared to 75% being recommended preventative therapy with a cardiovascular risk score of 10% or more. And when we look at those who accepted that recommendation, we can see that the majority of patients who were recommended, so 86% of patients who were recommended statin took it, versus a much lower percentage of patients in the randomized cardiovascular risk scoring. And that shows the impact of CT in identifying disease, but also in helping patients understand their risk and be willing to accept the recommendation for lipid-lowering therapy.
Pam, I'd love to hear your thoughts on this, the findings of fewer recommended for therapies, but people who were recommended more likely to actually start those therapies.
So there's a point made in the paper that The CT data, the CT angiographic data, taps into the health belief model better by showing that there is actually the presence of disease. And it's that certainty around risk and actual disease really helps people understand the challenges to their health that this represents. And that understanding, that belief, leads to changes in lifestyle and adherence to medications. This is instead of the possibility or the probability that's presented by a risk score. So certainty versus probability is, I think, where the impact is in actual healthy behaviors for individuals. In the Notify trial, there were actually, the primary endpoint was a statin, but there was actually substantial change in healthy lifestyle adherence as well. There's a couple things. One, that the risk is different by anatomy than it is by population epidemiologic profile. And that's a very important point. If we're going to practice personalized medicine, we really need to know about the risk in that person and not the risk in a population of similar people, because it does vary. And so that's a super important point. And the next point is that knowing that risk changes behavior and increases adherence to medications and healthy lifestyles. What the SCOT-HEART 2 parent trial will tell us is to complete the circle on that and tell us, does that improve health? Does that actually improve health? Because we kind of have process of care measures here, but we really need to know if this has an impact on who has a heart attack and who doesn't, and who lives and doesn't.
I'm a preventive cardiologist and see patients in clinic, and one of the hardest things for me is actually getting people to increase their physical activity, change their diet and lifestyle. Michael, would you summarize a little bit for the listeners what you found in terms of objective measures of physical activity and weight and other lifestyle measures in people randomized to the imaging versus the risk-based approach here?
I agree with you entirely. Trying to elicit change in a population that's often quite set in their ways and reluctant to change can be challenging. But what I would say, in those who did have coronary CT angiography, often at the follow-up visit, they came back and they reported that they did have a large impetus for change, as Dr. Douglas has already said. And one of the big things that we noticed was the change in the step count, which was a objective way of measuring the physical activity. Now, in those who were randomized to CT, again, we also self-reported physical exercise, and whether they adhered to the National Institute for Care Excellence guidance, and we saw that those with atheroma, those with proven coronary artery disease, 70% of them stated that they were more likely to adhere to those recommendations for exercise. I think that's probably one of the big things that I noticed at follow-up compared to those who had no atheroma or those in the cardiovascular risk scoring arm.
I really appreciated also seeing the data stratified by whether or not somebody had atheroma, because one of the concerns that's been raised about imaging is the flip side, where if people don't have atheroma, are they going to have a licensing effect where they can then maybe eat worse, exercise less, feel that prevention is not as important? And in fact, we saw even in those who had no atheroma on CT angiography who weren't randomized to statin, that they also had an increase in their step count. There was similar, if not more, benefit on lifestyle than those in the risk arm, which I think is reassuring for those of us who worry a little bit about the potential negative consequences of a reassuring scan and people who might still have risk factors or benefit from a healthy lifestyle. I want to ask Pam, was there anything in the results that you thought were either surprising or pleasantly reassuring to you?
One thing that was interesting was that there was no difference in outcomes between those who received a verbal report of their CT and those who actually saw their images. There's a literature on this that says that the actual image is more powerful than just the words, just the verbal report. And considering that it's a lot harder to get images to patients than it is to get words to patients, a note or a letter or a phone call, you don't need to figure out how to send PDFs and images and so on and point out the blockages and get pretty in the weeds. The patients just want to know the headlines, and that's enough. So that was one thing that I thought was important in the data.
Well, I want to congratulate Michael and all of your collaborators on this study for really a groundbreaking trial that's underway in SCOT-HEART 2 and a really important sub-study within that trial that informs us about how imaging may improve our ability to motivate our patients and improve cardiovascular prevention. Michael, could you just share with us a little bit about what more can we expect from either this study or future studies from SCOT-HEART 2?
Yes, excellent. From the sub-study perspective, I think we'll obviously follow these patients up as part of the main SCOT-HEART 2 study. In years to come, we might specifically look at this cohort of patients because, of course, this was a sub-study. So 400 patients within the main trial have had an intervention that other patients haven't had. So it'll be interesting to see whether this motivational interview, in addition to taking part in the study, has any impact on the long-term outcomes. But one of the things that we are currently doing just now is we're interviewing patients who've taken part, and we are doing a qualitative assessment about how they felt when they had their risk score, how they felt about their CT, and trying to understand a little bit more about what was the thought process of the patient receiving the information, not just about the 6-month effect, but what was it that led to the changes. And my colleagues at the University of Edinburgh, that's led by Dr. Amy Ferry, one of my nursing colleagues who I've worked with quite closely in the University of Edinburgh. And I know that they're getting quite close to obtaining all of that data, and we'll be sharing that in the not too distant future. In terms of the overall SCOT-HEART 2 trial, we're getting close to the end of enrolment. We're aiming for over 6,000 patients in the study, and we're getting close to 500, so we are almost there. Of course, it's a primary prevention study, so we will have to wait a little bit of time for events to accrue to determine whether or not the findings that we find in the impact paper do translate into reduction in cardiovascular death, and particularly a reduction in fatal and non-fatal myocardial infarction.
We look forward to all of this exciting results. For those of you listening who want to learn more about this study that we were discussing, check it out at JAMA Cardiology. I want to thank Dr. Michael McDermott and Dr. Pam Douglas for sharing your thoughts and wisdom with us today. Dr. Douglas is the senior author of an accompanying editorial on this manuscript, which provides some further insight into how this fits in with existing research and how it helps move the field forward. Thanks again for listening. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.